Hi class, welcome to fat-soluble vitamins. So today we're going to talk a little bit about vitamins in general, and then we're going to dive into some of my favorite vitamins, the fat-soluble ones. So let's start with a little bit of trivia. If a person has fat malabsorption issues, which nutrients might be of concern? Vitamin C, fiber, vitamin A, or vitamin B12? Hopefully you selected vitamin A because vitamin C and B12 are water soluble and fiber is not digested by us. How much energy do vitamins provide? 4 calories per gram, 9 calories per gram, or 0 calories per gram? Hopefully you selected 0. This was a very easy one. So vitamins are essential dietary components, and unlike the macronutrients, they do not provide us with any energy. So there are no calories provided from vitamins. However, despite not providing energy, they're actually absolutely essential for energy metabolism. So without vitamins, we wouldn't be able to produce energy in the form of ATP. They're also essential for cell growth, organ development, cognitive development, physiological development, and maintenance of our human body and genome. So we cannot live without vitamins. We can classify the vitamins into fat-soluble vitamins, which include D, E, A, and K, and water-soluble vitamins, which include the B vitamins and vitamin C. They have many different characteristics based on their solubility. So fat-soluble vitamins are primarily transported through the lymphatic system. Many of them need chylomicrons to be transported or lipoproteins. Water-soluble vitamins can be absorbed directly into the bloodstream. And so those are just a few of the differences. Vitamins cannot be made by the body. However, our body does have some precursors to vitamin, and depending on the conditions, for example, with vitamin D in the sun, we may be able to make vitamins. But generally speaking, we need to consume vitamins in our diet unless the correct conditions are met. Even at low levels of vitamin deficiency, we can see health span and lifespan affected. So we can have clinical versus subclinical deficiencies. And a clinical deficiency is where obvious signs and symptoms of that deficiency are present, such as with scurvy, a vitamin C deficiency that causes bleeding gums. But a subclinical deficiency may exist if somebody's getting kind of a slightly inadequate level of vitamins or minerals in their diet, but it's not showing any overt symptoms. So we don't see that they have bleeding gums, but we do see that maybe they have some neurological issues, maybe they have some skin issues, kind of smaller, lower level symptoms. Some vitamins can actually be used as pharmacological agents. So niacin, for example, which is one of our water-soluble vitamins, has been used to lower blood pressure. And where do we get vitamins? We get them from plant and animal food sources. Some are actually made by bacteria in our intestinal tract, for example, vitamin K and biotin. Absorption of vitamins. So I was hinting to the fact that fat-soluble and water-soluble vitamins are absorbed differently. And like I said, most fat-soluble vitamins rely on chylomicrons, lipoproteins for transport. The fat-soluble vitamins will rely on bile because bile is going to help them interact with these different components, as well as pancreatic lipase, which is an enzyme from our pancreas that helps to break apart lipids. They have to be absorbed from the small intestine, so in any disease where there is intestinal inflammation or intestinal malfunction, those vitamins are not going to be able to pass across the intestinal cells or enterocytes to either enter the bloodstream or the lymphatic tissue. So in some cases of GI disease, we do see fat malabsorption. Also in issues of pancreatic disease, we see fat malabsorption. In issues of alcoholic disease, we see that alcohol actually blocks absorption of primarily some of the water-soluble vitamins. This is just an FYI slide, but this is a slide I actually love a lot and have used in my clinical practice. And so this is the GI tract from kind of top to bottom, starting at the esophagus, going down to the large intestine. And you can see which vitamins and minerals are absorbed at every single part of the GI tract. And so the way that I would use this diagram is if I met with a patient who had had a GI surgery, or maybe a gastrointestinal cancer, or even a gastric bypass, I would know which part of their intestine or GI tract had been affected, and that would clue me into possible vitamin or nutrient deficiencies that they may be at risk for. So, for example, in some types of gastric bypass, they remove a portion of the stomach. They generally remove the duodenum, and some gastric bypasses remove part or all of the jejunum and may just leave it with the ileum. In certain cancers, such as colon cancer, you're going to maybe have part of the large intestine removed or infected, etc. So I would use this chart to kind of get a red flag, raised for my patients and say, okay, you're missing this part of your GI tract. What vitamins and nutrients might you be at risk of deficiency for? Transportation of vitamins. So I've already discussed this a little bit with the fat-soluble vitamins, and we'll talk specifically about each one. For most of the fat-soluble vitamins, they'll be transported with the chylomicrons, which are like fat taxis. They'll go through the lymphatic system, which the lymphatic system drains to the liver. The liver will then repackage them and transport them via transport proteins to cells in the body. That's what will happen for the majority of the fat-soluble vitamins. The water-soluble vitamins don't need fat taxis to transport them. They can be absorbed directly into the bloodstream through the intestinal cells and then distributed through the body to where they're needed. So that's part of the difference in the classification of these two vitamin types. Storage of vitamins. For the most part, fat-soluble vitamins are stored in the body, and for the most part, water-soluble vitamins are not. However, there are some exceptions. So vitamin K is an exception. We do not store a lot of vitamin K in our body. Vitamin K is one of our fat-soluble vitamins. And then vitamin B12 and B6, we actually do store in our body, in the muscle and the liver. And so those are exceptions to the water-soluble vitamins that are stored. Since, in general, fat-soluble vitamins are stored easier and more difficult to excrete than water-soluble vitamins, we don't have to consume fat-soluble vitamins as frequently because we generally have these kind of large stores of them in our body. Since water-soluble vitamins are excreted easily via the urine, the feces, etc., even the sweat in very small doses, we have to consume most water-soluble vitamins much more frequently. Vitamin toxicity. So there is toxicity possible from many of the different vitamins. Specifically with vitamin A and D, if you're taking very high levels of these, generally this is going to happen from supplement sources versus natural foods. But there is a possibility of vitamin A toxicity from a specific food source, which is actually liver of a polar bear. So if you are eating liver of a polar bear, you may be at risk for vitamin A toxicity because it's such a concentrated source. So let's dive into the fat-soluble vitamins. And remember, these include D, E, A, and K. Vitamin A. So vitamin A includes preformed retinoids and provitamin A carotenoids that can be converted to vitamin A activity. And I have the picture of the carrots here because we do see carotenoids in these carrots, and we also see them in other foods of this color. So the carrots are orange, but they also have these green stems. We do see a lot of kind of our provitamin A, or something that can be converted into vitamin A in the form of green, orange, kind of yellowish veggies. We do also find vitamin A in animal sources, which we'll talk about coming up. And vitamin A is good for our vision. So you may have heard that eating more carrots would help your vision, and that is actually mostly true. So it is found in foods as a preformed or a provitamin. The preformed vitamin A is found in retinoids, and so retinoids are considered to have preformed vitamin A activity. Retinoids generally come from animal sources, and there are 3 different forms of retinoids that can be converted. There is retinol, and retinoic acid. And provitamin A is found in the form of beta carotene. There are actually many different carotenoids, but beta carotene is one of them with the most provitamin A activity. So we can convert beta carotene actually into a preformed vitamin A, and then that can turn into active vitamin A. You can see on this diagram on the right that all of these molecules have a 6-carbon ring on the left, and then it's kind of their tails that are different. So beta carotene is very large and actually looks like kind of 2 molecules of itself just split and multiplied. Retinal has an aldehyde group at the end. Retinol has an alcohol group at the end, and retinoic acid has an acidic group at the end. This is a pathway diagramming how beta carotene can be converted to retinal or retinoic acid, or how we can interconvert the different retinoids. So we can have retinol esters, which can be converted to retinol, which can be converted to retinal. The conversion from retinal to retinoic acid is irreversible, but the other parts of this pathway are not irreversible. So what does vitamin A do? Vitamin A is very important for our vision, and it plays a role in multiple aspects of vision. So it helps form part of our cornea, which is our lens, and it also helps make up rods and cones, which allow us to see kind of light and dark vision. So it's very important for night vision. It also protects our eyes from excessive dryness and helps maintain the membranes in our eyes. It's important for development, growth, and immunity, so specifically the formation of the eyes, the limbs, the cardiovascular system, and the nervous system. And it's also involved with forming some of the epithelial cells, which are cells that line and help form mucus-forming cells in the lung, the trachea, the skin, and the GI tract. It's important to reproduction, and too much or too little vitamin A can cause significant reproductive errors and neurological issues, as well as physiological issues for children. It's important for bone growth, and it works as an antioxidant, so it can scavenge free radicals. Other functions it has been used in acne treatment because of its role in cell differentiation. It's been used in psoriasis, which is an immune system disorder where you have chronic inflammation of your skin and you can get kind of these red, patchy, scaly marks. And it's been used in the immune system to help boost the immune system. Vitamin A in foods, so I mentioned the carrots and the green and yellow-orange compounds, and I also mentioned animal sources. So the retinoids, which are considered the preformed vitamin A, are found in animal sources, so liver, fish oils, fortified milk, and eggs. And liver is one of the most rich sources of vitamin A, which is why I mentioned if you happen to be eating a lot of liver, specifically of the polar bear species, you can actually get too much vitamin A. And for pregnant women who are consuming other sources of vitamin A, it's actually recommended that they do not eat excessive liver. Most people currently are not eating that much liver, but it is making a comeback. It was kind of a generational thing that was skipped by the millennial generation, but it is kind of making a comeback as a health food due to its richness in many of these vitamins. We can also find retinoids in fortified margarine, and then we have carotenoids. And carotenoids are a group of compounds found in the green and yellow-orange vegetables, and there are many carotenoids. Other carotenoids include lycopene, lutein, and zeaxanthin, but beta-carotene is the carotenoid that has the most pro-vitamin A activity. So like you saw in the last slide, we can convert beta-carotene to retinol and retinoic acid. In North America, most of our vitamin A comes from animal sources, so most of them is coming in the retinoid form. In other countries, most of theirs comes in a carotenoid form where they're eating less meats. Dietary vitamin A is expressed in retinol activity equivalents, and this is meant to account for the different ability of certain compounds to be converted to retinol. So we saw that beta carotene could be converted to retinol, but we'd have to consume a lot more beta carotene to make one molecule of retinol than if we just consumed retinol itself. I did mention that some of the other carotenoids could be converted to vitamin A, but not as efficiently as beta carotene. And so for some of the other carotenoids, we need even more of them to make one molecule of retinol. This is another chart showing some food sources of vitamin A, and you can see that beef liver is one of the richest sources, but then also some of these green and orange colored fruits and vegetables, as well as a little bit in dairy. Mostly this is stored in the liver, so that's why the liver is so concentrated. In animals, it can also be stored in the kidney, the bone marrow, the adipose tissue, the testicles, and the eyes. And most Americans in North America are eating enough to meet their DRIs for vitamin A, which it happens to be 900 micrograms for men and 700 micrograms for women. So vitamin A's role in vision. Retinal, it has an A, that is the form of the retinoids that is important to the retina, which is in our eye. So retinal is the form that's important for our eyes. And it's also important for formation of rods and cones. Rods help us see black and white, and cones help us see color and are involved in bright light vision. Rods are more involved in dim light vision, so when it's dark outside or becoming dark. This is vitamin A's role in vision in a lot of detail. So there's a molecule in the eyes called rhodopsin, and rhodopsin is made out of something called an opsin and a molecule of retinal, or vitamin A. This is the light-sensitive pigment in the retina, and what happens is when we're exposed to light, so say it's a dim setting, it's kind of dark outside, when we're exposed to light, this molecule goes from its cis transformation, the retinal goes from a cis transformation to a trans form. So remember, cis and trans had to do with orientation of carbons around a double bond. And when it changes from cis and trans, a chemical cascade is produced that sends signals to the brain and allows us to interpret the image. The problem with this is then we have a bunch of trans retinal. And we can't use transretinal to see in this dim light. And so what we have to do is we have to regenerate cisretinal, which is fine, but it takes quite a long time. It can take, 5+ minutes to regenerate that transretinal and convert it back to a cis form so that it can act as a photoreceptor again. For people with plenty of vitamin A, they can just grab another molecule of retinol to bind to opsin and create rhodopsin and have this process repeat over and over again with no issues. However, if somebody is deficient in vitamin A, they won't have a pool of retinol to pull from to bind to opsin again, and they'll have to wait for those retinol to be changed from the trans form back to the cis form. So if they're having to wait, this can actually cause diminished vision in dark situations and can actually lead to night blindness. This is from your book, and I did not include it in the student slides, but like I said, it's from your book. And this is showing kind of what happens in dark and light cycles. So say you're in the dark and you see a flash of the camera. This is what happens within your eye so that your eye adjusts to that flash and then is able to go back to see in the dark again. So a rhodopsin molecule has a molecule of opsin and retinol. That retinol is in the cis position. When you see light, it changes to the trans position. And the trans position, the trans retinol will be removed from the opsin molecule. Then a signal to the brain will be generated, and it takes a while for that retinol, which you can see in the blue arrows, the retinol to be converted back from trans to cis so that it can bind to the opsin again. And so this is what will happen. If you have to wait for that retinol to be converted from trans to cis, it can take a long time before you're able to readjust to light again. But if you have extra vitamin A or plenty of vitamin A, you can just draw from another cis retinol and attach it to opsin while you wait for your other molecules of retinol to regenerate. So deficiency of vitamin A can contribute to night blindness, inability to see in dim light, inability to adapt to light in a dark situation. And this is a huge problem worldwide. 250 to 500,000 children are affected by night blindness each year, and there are 250 million children who are considered to be vitamin A deficient. Okay, the carotenoids. So specifically, beta-carotene does have some pro-vitamin A activity, but there are other carotenoids as well that play significant roles, and they are fat-soluble. They're found in fruits and veggies, so colorful fruits and veggies are important. They play a role in eye disease, so specifically macular degeneration, which I have a picture of coming up. And specifically for eye disease, we have something called lutein and zeaxanthin that are found in green leafy veggies, tomatoes, also a little bit in eggs. They're actually found there. They're important for the immune system. So vitamin A is very important for the immune system as well as the carotenoids. They're important for cancer. Lycopene, which is found in tomatoes, higher lycopene intakes have some correlation to lower risks of prostate cancer, but again, correlation is not causation. And they play a role in cardiovascular disease. So the carotenoids can help protect LDL cholesterol from being oxidized, which oxidized LDL cholesterol can contribute to atherosclerosis, narrowing and hardening of the arteries. And so by protecting that from happening, it can reduce risk of heart disease. Beta-carotene does act as an antioxidant. There are other carotenoids as well that do have some antioxidant roles, and there is no upper level, especially from beta-carotene, so you can eat as many carrots you want. Since beta-carotene plays an antioxidant role, we would think that it would be a great antioxidant supplement, but it doesn't actually seem to be as efficient in a supplement form as it is from whole foods, which just looking at the types of foods that have it, you may guess why. But they actually did a study in smokers who are at high risk for oxidative damage, and they gave them beta-carotene, and they found that it actually made lung cancer worse when they took it in supplement form, but not food form. Vitamin A deficiency diseases. So like I said, night blindness is a huge issue. We do not see this very much in North America because we have a lot of vitamin A in our different foods that we eat. However, it is seen in developing countries. We do see it a lot in Africa, Asia, South America, Malaysia, Indonesia, etc. And people who are at risk of developing vitamin A deficiency disease, anybody who's living in poverty, alcoholism, or liver disease, we see limited vitamin A storage. Anybody who has fat malabsorption, so if they're unable to digest fats, so maybe something like celiac disease, cystic fibrosis, if somebody has excessive diarrhea, HIV/AIDS, Crohn's disease, any pancreatic disease that's limiting pancreatic lipase may develop vitamin A deficiency. It can lead to night blindness. It can also lead to drying of the eyes, different spots on the eyes. In the skin, it can lead to something called keratomalacia, keratomalacia, which is kind of like a dryness of the skin, which you can see here. Growth impairment can be seen in children, so we can see stunting. If it's in infancy, certain organs may not form appropriately, and then impaired immune function. Children with vitamin A deficiency, or actually anybody with vitamin A deficiency, is more susceptible to diseases like malaria, HIV, etc. And HIV transmission is more likely to happen in somebody who's vitamin A deficient than not. These are different pictures of issues that could result from vitamin A deficiency. So the upper left is a blurry child, and that's how your vision would look if you had age-related macular degeneration. The lower left is something on the eye. It's called a bigot spot, and it's a dry, foamy area in the eye that can be caused by vitamin A deficiency and hardening of these epithelial cells. Remember, I discussed that vitamin A was needed to form mucus and epithelial cells. So without it, you can have this bigot spot. This can lead to scarring in the upper right. You do see some scarring. You see that the cornea is damaged. The cornea has been softened. And instead it's replaced by carotenoids tissue. And so this person is blind due to vitamin A deficiency. Vitamin A toxicity is possible, and it is called hypervitaminosis A. We can see this occurring with long-term supplementation. So if you're taking retinoids but not beta carotene, you can have vitamin A toxicity. We can see acute toxicity, so maybe you took a really high dose but just for a few days, and acute toxicity may lead to GI issues, headache, blurred vision, muscle coordination. It can actually kill adults and children. So say maybe they got into a supplement vial, or like I said, maybe they ate an entire polar bear liver, but 500 milligrams in children and 10 grams in adults can actually be fatal. Chronic vitamin A toxicity can cause joint pain, skin disorders, headache, liver damage, double vision, loss of appetite, and can interfere with blood clotting. And then teratogenic vitamin A deficiency has to do with vitamin A harming the developing fetus. And so if a pregnant woman is taking too much vitamin A, her child can be born with birth defects. Commonly we see ear canals not formed appropriately or totally, and you can even see miscarriage, etc., infant death with high dose vitamin A. So pregnant women should not take vitamin A supplements unless instructed specifically to do so by their doctor. And if you are taking acne medication such as Accutane or any other containing vitamin A, you have to be on birth control, and it is not recommended that you get pregnant, and many doctors will actually require monthly birth control tests or monthly pregnancy tests to confirm that you're not pregnant, since it's so harmful. This is a spectrum starting at death and then deficiency of vitamin A with normal function from vitamin A and toxicity at the right side. So we do see both deficiency and toxicity with vitamin A. As far as when this could happen, it's generally not going to happen from carotenoids because the carotenoid conversion to vitamin A is very slow. And as we eat more carotenoids, so say our carrots, we actually have decreased absorption, so we don't have as much toxicity. Our bodies could turn orange. We may see some orange deposits under the skin, but will not have toxicity. We mostly see this from supplement forms. Our next fat-soluble vitamin, vitamin D. So vitamin D is a special vitamin because it actually is a prohormone, a precursor to an active hormone and a vitamin. And this is kind of a conditional vitamin because if we have the components in our skin and we go out in the sun, we actually can make this from the sun. So we don't necessarily have to consume orally vitamin D. They kind of discovered vitamin D in the early 1900s, where they saw some animals with rickets, which are bowed, kind of inappropriately mineralized bones, and they cured them by feeding them cod liver oil, which cod liver oil is very rich in vitamin D. So the sun is a significant source of vitamin D for many people, and diet is also a source of vitamin D. We do see it in naturally occurring foods such as salmon. However, it's also added to many fortified foods. The active form of vitamin D is called cholecalciferol. And in our skin, we have kind of this pre-vitamin D3, which is 7-dehydrocholesterol. When 7-dehydrocholesterol is exposed to UV light and heat, it can form the active vitamin D3, which is cholecalciferol, which then travels to the liver and the kidneys, where oxygen and hydrogen groups are added and forms something called calcitriol, which is biologically active. So this is a little diagram of that. Here's our skin. We have something called 7-dehydrocholesterol in there. With UVB radiation, that 7-dehydrocholesterol is converted to pre-D3. With heat, it's converted to vitamin D3, which is cholecalciferol. Vitamin D3 can then travel to the bloodstream, bind to vitamin D transport protein, then travel to the liver and kidneys, where an oxygen and hydrogen group will be added so that it's in its active form. And sun exposure can provide 80 to 100% of our vitamin D needs. As far as skin synthesis goes, if we're making a lot of vitamin D3 from skin and we have adequate levels of it, it will actually just be degraded, and so we will not have any toxicity risk from sun sources of vitamin D. Vitamin D3 formation in the skin. So like I said, when you are exposed to the sun, it generally takes 10 to 15 minutes of exposure 2 or 3 times a week. It may take longer for darker skin. And primarily the arms, the face, under the eyes, etc. are kind of prime areas. But when you're exposed to adequate vitamin D, you can make it, or adequate sun, you can make vitamin D from the sun in this process in your skin. This can vary based on geographic location. So you can see the equator in the middle and how intense the UV rays are near the equator. You'll have a much higher conversion rate near the equator than farther from the equator. So you can see very northern parts, say, of Alaska and Canada, you're not going to have very intense UVB rays, or you may not have them for significant parts of the day, so your vitamin D making potential from the sun would be decreased. Season can vary vitamin D making ability. So, for example, in San Luis Obispo, we can make vitamin D probably 95% of the year, but maybe northern areas, say Boston, for example, maybe only, maybe November through February are a little bit darker, less sunny, and so maybe they won't be able to make as much vitamin D. Age can affect synthesis rates. Skin color, people with higher melanin content, which is a darker pigment in the skin, actually have reduced vitamin D synthesis. And sunscreen can also cause reduced vitamin D synthesis. So anything over SPF 8 can reduce UVB rays, which can reduce exposure. So it's actually pretty common for people to be deficient because many people will wear sunscreen or hats or sunglasses or long sleeves out in the sun just to cover up and protect themselves from these UVB rays. And if we're covered up, we can't synthesize it. Vitamin D in foods. So there are a couple different forms of vitamin D found in foods, and there's vitamin D2, which is primarily produced by plant foods on their own exposure to UV light. So for example, mushrooms exposed to UV light produce vitamin D2. And vitamin D2 is sometimes found in fortified foods. There's also something called vitamin D3, which is found primarily in animal products. And so some sources are listed there. This is a picture of a child consuming cod liver oil, and that was a really common children's supplement prior to fortification. Now we can find vitamin D in milk and orange juice and breakfast cereals, breakfast bars, all sorts of much tastier food than cod liver oil. I can't imagine taking this as a child or really ever. Other sources are seen here, and the adequate intake levels, they do increase with age. So you can see that for 70 plus years, they are 100. Actually, you can't see that from this chart, but I'll tell you. So for 70 plus years, they're 800. For 1 to 70, they're 600. And this was actually increased from 1997 to 2010. So in 2010, the Institute of Medicine increased the adequate intake level for older adults, specifically because their reduced ability to synthesize it from the sun. This is a picture of how it could be synthesized from the sun, as well as food sources contributing to vitamin D in the diet. Whether it comes from the sun or from food sources, it will travel through the bloodstream to the liver and the kidneys, where it is hydroxylated or has this oxygen and hydrogen group attached to it so that it is its active form. Functions. So many people know that vitamin D is important to our bones, but it also plays many more functions than that, many more roles than that. And so when we have the active form of vitamin D, which in this diagram is D3, 125OH2D3 is calcitriol, and that's considered the active form. One of the main things that that does is it helps to balance calcium and phosphorus levels in the blood. So if calcium and phosphorus levels in the blood are low, it will increase calcium and phosphorus absorption from the intestinal tract, and it will pull from the bone. Generally, we're more at risk for low calcium than low phosphorus, as phosphorus is added to tons of foods as a preservative and food stabilizer, and it's also found naturally in foods. But most people don't get enough calcium. We generally get enough phosphorus, but not calcium. So the bone will pull, or the vitamin D will cause calcium to be pulled from the bone if needed. And it doesn't do this single-handedly. There's many other hormones involved as well as glands. So there's something called the parathyroid gland, which makes parathyroid hormone, and that plays a role as well. So vitamin D will help keep calcium levels stable in the blood, but can do so at expense of the bone via parathyroid hormone. It also plays a role in immune function. So people with low levels of vitamin D tend to have decreased, weakened immune systems. It's important for secretion of other hormones such as insulin, renin, parathyroid hormone. It may play a role in autoimmune diseases such as multiple sclerosis. It may play a role in depression, anxiety, dementia, all sorts of psychological mental disorders, as well as infections, cancer, etc. Breast, prostate, colon, we're looking at vitamin D for. Rickets. So, if you do not have enough vitamin D during childhood, something called rickets can develop. And in rickets, because of the lack of vitamin D, you're not able to deposit calcium into the bones. And the bones become kind of soft. And under pressure or under weight of the body, they can bow and they can break and they can flex. And over time, this can actually cause permanent deformations of the bone. You can see these different pictures here, some breaks as well as some significant bends, especially in the bottom picture. And this can cause lifelong implications. You can get braces to kind of fix this issue, but it's a very long and arduous process. These are the leg bones shown, but this can also affect the head, the joints, the rib cage, the pelvis, really any bone in the body. We see it more obviously in the legs because those are the weight-bearing bones. If this happens in adults, it's called osteomalacia, and a similar kind of presentation may form, however it develops later in life. In vitamin D toxicity, we do see some issues. So we don't see this from the sun. It does occur from supplements. And above really high levels, so above 100 micrograms, or sorry, above 100 milligrams, or in international units, it's 4,000, it is possible to see some issues. So, since it increases absorption of calcium, it is possible that it leads to high blood calcium levels. Hopefully that calcium goes to the bones, but it does not always because it needs something to get there. That something is vitamin K, as well as many other factors. But if it doesn't go to the bones, it ends up depositing in the very small vessels, and this causes something called calcification. It can happen anywhere in the body, the kidneys, the heart, the lungs, the eyes. This is a picture of it happening in the hands. So these are little tiny bones that have formed all over somebody's hands. They're calcified. It can cause nausea, vomiting, bone demineralization, muscle weakness, joint pain, neurological issues, death. Vitamin E. So vitamin E is a collection of molecules called tocopherols or tocotrienols, and there are 4 tocopherol molecules and 4 tocotrienol molecules. But the most active form is alpha tocopherol. There is alpha, beta, gamma, and delta tocopherol and trienol. Like I said, alpha is the most active form of a tocopherol, but there's also something called gamma tocopherol, and we're learning more and more about gamma tocopherol every day. It has some antioxidant functions, and so there's some new evidence about that. But mostly we're going to be talking about alpha tocopherol. It plays a role as an antioxidant, stabilizing membranes and lipids. It helps protect cells from oxidative damage, and it may play a role in heart disease risk. And it's not the only tocopherol that could play a role in heart disease risk. I have a question mark there because the evidence on that is slightly mixed. As an antioxidant, it helps protect the cells against oxidative damage. And what happens in oxidative damage is there will be molecules with unpaired electrons, and those molecules, they're called free radicals, with unpaired electrons will steal electrons from normal cells or healthy molecules to balance out their unpaired electron. If they steal an electron from a normal cell, that cell will be unstable and oxidative damage can occur, and that cell can break, shrink, lyse, lose its cellular integrity and stability. And so vitamin E plays a big role in protecting the cells against this by acting as a hydrogen donor and kind of stopping this from happening. This is a picture of vitamin E within a cell membrane, and our cells are generally phospholipid. There's a phospholipid bilayer that makes up cell membranes. So phospholipid is a type of lipid with a phosphate molecule, and these membranes are very at risk for free radical damage. Free radicals have unpaired electrons. Vitamin E can be an electron donor. to prevent and stabilize that membrane from being damaged. The only thing is, as vitamin E donates its electrons, it can be kind of like used up in the process. It only has limited electrons to donate, and so we need adequate amounts of vitamin E to continually serve this role as an electron donor and protect the cells. Food sources of vitamin E. So these are some pictures of food sources of vitamin E. It's found in plant oils and products made from plant oils. So it's found in a lot of salad dressings, shortenings, margarine. It's found in avocado, almonds, peanuts, sunflower seeds, etc. It is susceptible to being destroyed by oxygen, light, and heat. So if you're using vegetable oils, but you're frying them really high heats, you're actually potentially destroying the vitamin E. If they're exposed to a lot of light, you're destroying the vitamin E, and oxygen can also destroy vitamin E. Additional sources pictured there, so really rich in seeds and nuts. And then absorption and excretion. So most of it is absorbed via passive diffusion, and we do need bile and pancreatic enzymes in order for this to happen. So it will be incorporated into chylomicrons, it will be transported through the lymphatic system to the liver. Once it gets to the liver will repackage it into other lipoproteins. Lipoproteins then head out to the body to deposit their contents, and they'll distribute them to other cells. We don't store a lot of vitamin E in the liver, where we do store other fat-soluble vitamins in the liver. Most of the vitamin E that we do store is in the fat cells. And vitamin E doesn't have a specific transport protein, unlike some of the other fat-soluble vitamins. So that's why it's just transported by our fat taxis, our LDL, our chylomicrons, our VLDL, etc. Vitamin E deficiency. So kind of like our other fat-soluble vitamin, we do see deficiency in people who have fat malabsorption, so cystic fibrosis, intestinal disorders, pancreatic disorders, because we do need those pancreatic enzymes, fat absorption, bile, etc., for this to be packaged into chylomicrons. We do see deficiency in smokers because they do have high rates of oxidative damage, and we do see deficiency in preterm infants. Some of the signs of deficiency include hemolytic anemia, which is where the red blood cells have been damaged and they can actually burst and lyse, which makes them unable to carry oxygen. We can see immune deficiency, and we can see neurological changes in the nervous system, both within the spinal cord and peripherally to the hands and feet. We do also see increased oxidative damage at the cellular level that can lead to organ damage that accumulates. Excessive vitamin E can interfere with vitamin K's role in blood clotting, and so megadoses of vitamin E can actually lead to bleeding, and so we have to monitor this in people who are at risk for this deficiency. Vitamin K. So I just mentioned vitamin K's role in blood clotting. Vitamin K actually came from the word coagulation, which starts with a K in Danish. It was a Danish spelling of it. And coagulation is blood clotting. We spell it with a C in the United States. So vitamin K, like some of the other compounds, is a family of molecules, and it includes phyloquinones and menaquinones. And phyloquinones come from plant species, and phyloquinones make up what's called vitamin K1. Vitamin K1, it is biologically active, so is vitamin K2 though, but the majority of our North American diet is from vitamin K1 foods. Vitamin K2 or menaquinones are made by bacteria in our large intestine, or they're made by bacteria in foods, or they are found to some extent in the liver. Sources. So 10% can come from bacterial synthesis. This is primarily vitamin K2. However, there are bacteria within foods that do ferment to produce vitamin K2. And so on the bottom right hand of this slide, there is a fermented soybean product called natto, and it's made with a bacteria called Bacillus natto that ferments it to produce vitamin K2. And it is very common in Japan and Japanese cultures. And this is the richest source of vitamin K2 out there. You can buy it locally. There's an Asian market downtown on Monterey Street. They sell it there. It's in the freezer section. I've bought it. It's an acquired taste, but it's not that bad. It's tolerable. It comes with a little kind of vinegary sauce to put on it. So that's a really rich form of vitamin K2. Leafy greens are a really good source of vitamin K1. And then goose pate is a really rich source of vitamin K2. Soft cheeses and hard cheeses are also significant sources of vitamin K2. It is stable to heat, but light can destroy it. And these are some other sources. It's really, really rich in dark green leafy vegetables. There is no upper limit for it. Adequate intakes 90 for women, 120 for men. We don't have enough information to determine the EAR and the RDA. And I actually counsel patients a lot on vitamin K intakes, mostly in the setting of if they're taking blood thinning medication. So what does vitamin K do with regards to blood clotting? Vitamin K is needed to activate the clotting cascade that helps form a blood clot. So say we get cut and our finger's bleeding, like in this picture. There's a whole cascade of events that happen in order for us to form a clot at that site and stop the bleeding. And so one of the things that happens in the first part of this cascade is a molecule called prothrombin is converted to thrombin. And we can't do that without vitamin K. So we cannot initiate the clotting cascade without vitamin K. Thrombin then converts fibrinogen to fibrin, which fibrin is kind of this thready material that forms the blood clot. But without vitamin K, we would not be able to do this. People who take blood thinners are trying to avoid blood clots. And so actually giving them a lot of vitamin K kind of overrides the role that the blood thinners are playing and counteracts the role of those blood thinners. So often people on blood thinners, I have to counsel about sources of vitamin K and to not eat them, although normally they'd be healthy to eat. Vitamin K2 specifically plays a role in bone metabolism and heart health. And one of the things that vitamin K2 does is it works with something called matrix GLA and osteocalcin, and it helps bring calcium from the bloodstream into the bone to reduce our risk of osteoporosis. And by bringing calcium out of the bloodstream and into the bone, it also helps reduce that calcification of the arteries, which we saw in vitamin D toxicity. This is the clotting cascade pathway in detail, which you do not have to know for this class, but I like to point out that vitamin K is absolutely necessary for the conversion of prothrombin to thrombin. And you also see calcium playing a role. So both calcium and vitamin K are important for blood clot formation. Vitamin K deficiency. So we do see vitamin K deficiency in infants. We also sometimes see it in impaired fat absorption, so cystic fibrosis, intestinal disease, pancreatic disease. We sometimes see it in long-term antibiotic use because our bacteria won't be producing any of our vitamin K, but generally speaking, that's an insignificant contribution of our total vitamin K. Since infants have sterile guts, mostly sterile, 99% sterile, that means they don't have a lot of bacteria producing vitamin K for them yet. And most infants aren't born eating kale and leafy greens. So infants at birth are given injections of vitamin K into their heels to prevent hemorrhage and bleeding. They could be at risk for bleeding to death without vitamin K. If you don't have enough vitamin K, you can have bleeding. And I didn't show a gory picture of bleeding because I'm sure you can use your imaginations. But this is a bruise underneath the skin, which could be a result of internal bleeding and may be related to vitamin K deficiency. Vitamin K toxicity, there's no upper limit. Like I said, it is stored in the liver, hence the goose pate being a very high source of it, and it is easier excreted than other fat-soluble vitamins. This is a fantastic table/chart from the end of your chapter that I would highly recommend you committing to memory. It just has very brief kind of summaries of functions, deficiency, people who may be at risk, sources, etc. for the different fat-soluble vitamins that we've discussed. And a tiny bit more trivia. What could happen if you ate a 5-pound bag of baby carrots every day? Hopefully you said your skin will turn orange. It could. It doesn't mean it will, but it could. Who could benefit from adding vitamin D to their diet? An athlete drinking milk, a young child in Santa Barbara, California, or a middle-aged woman working full-time in an office in Montreal, Canada? Hopefully you said C. All right, the end. Thanks for listening. Bye.